Regaining stability and balance. There are multiple factors that impact balance, including muscular weakness, proprioceptive deficits, and range of motion deficits. Balance is critical in dictating movement strategies within the closed kinetic chain system. Balance is highly integrated and is a dynamic process. Postural equilibrium is a broader term that incorporates the alignment of joint segments, including maintaining the center of gravity within the limits of stability. Balance is a vital component in rehabilitation. This includes things like joint position senses, proprioception, and kinesthesia. This is critical to include a combination of open and closed kinetic chain exercises. The postural control systems. We have sensory detection of body motions. This leads to the integration of sensory motor information within the central nervous system, and then an execution of musculoskeletal responses. Balance should be considered both dynamic and static processes. The successful accomplishment of static and dynamic balance is based on the interaction between the body and the environment. This figure shows the complexity of this dynamic process. From a clinical perspective, separating the sensory and the motor process of balance means that a person may have impaired balance for one or a combination of two reasons. Disrupted balance occurs due to two factors. The position of the center of gravity relative to the base of support is not accurately sensed, or automatic movements required to maintain the center of gravity are not timely or effective. The human body is a very tall structure, balanced on a relatively small base of support, and its center of gravity is quite high, being just above the pelvis. Balance relies on a network of neural connections and centers that are related by peripheral and central feedback mechanisms. The postural control systems operate as a feedback control circuit between the brain and the musculoskeletal system. The source of afferent information supplied to the postural control system collectively come from visual, vestibular, and somatosensory inputs. The central nervous system's involvement in maintaining upright posture can be divided into two components: the sensory organization and muscle coordination. Sensory organization involves the processes that determine timing, direction, and amplitude of correction based on information from the vestibular, visual, and somatosensory or proprioceptive units. Despite the ability of multiple sensory inputs, the central nervous system generally relies on only one sense at a time for orientation. For adults, the somatosensory system is relied on primarily. For healthy adults, the preferred sense for balance control comes from somatosensory information. An example of this would be when the feet come in contact with support surfaces and we detect joint movement. Muscle coordination is the collection of processes that determine temporal sequencing and the distribution of contractile activity of the legs and trunk that generate supportive reactions for maintaining balance. A patient may be inappropriately dependent upon one sense for situations, presenting intersensory conflict. Balance deficits can occur. They occur through inappropriate interaction among the three sensory inputs. A patient that is dependent upon one system may be presented with intersensory conflict. A patient may be inappropriately dependent upon one sense for situations. We get sensory input from three areas. Somatosensory is also known as proprioceptive feedback. This provides information concerning the relative position of the body parts to support surfaces and to each other. Vision is the measure of orientation of the eyes and the head in relation to surrounding objects. This plays an important role in maintenance of balance. On a stable surface, closing the eyes should cause only minimal increases in postural sway in healthy patients. If somatosensory input is disrupted because of ligamentous injury, closing the eyes will increase sway significantly. The vestibular system provides information dealing with gravitational, linear, and angular accelerations of the head with respect to inertial space. It does not, however, provide orientation information in relation to external objects, and therefore plays only a minor role in the maintenance of balance when the visual and somatosensory systems are operating correctly. The terms somatosensory, proprioception, kinesthesia, and balance are often used to describe similar phenomena. Somatosensation is more of a global term that is used to describe the proprioceptive mechanism related to postural control. Somatosensation is best defined as a specialized variation of the sensory modality of touch that encompasses the sensation of joint movement, also known as kinesthesia, and joint position, which is the joint position sense. Balance refers to the ability to maintain the body's center of gravity within a base of support. Somatosensation and balance work closely as the postural control system uses sensory information related to movement and posture from the peripheral sensory receptors, such as the muscle spindles, Golgi tendon organs, joint afferents, and cutaneous receptors. So, how does proprioception influence postural equilibrium and balance? Somatosensory input is received from mechanoreceptors. The stretch-related reflex is the earliest mechanism for increasing the activation level of muscles about a joint following an externally imposed rotation of the joint. The stretch reflex triggers activation of the muscles about a joint due to perturbation. This results in a muscle response to compensate for imbalances and postural sway. The rotation of the ankle is the most probable stimulus of myotatic reflexes. Muscle spindles sense a stretch of the agonist, thus sending information along its afferent fibers to the spinal cord. The information is then transferred to the alpha and the gamma motor neurons that carry information back to the muscle fibers and the muscle spindle, which then contracts the muscle to prevent or to control additional postural sway, maintaining postural control. Research suggests proprioceptive information from pressure or joint receptors plays an important role in postural stabilization. Visual information can compensate for the loss of proprioceptive input. The stretch reflex helps control the center of gravity, and the proprioceptors in the gastrocnemius and the tibialis anterior can provide necessary information to maintain stable standing in the absence of feedback from the feet and the ankles. We're going to go through a lot of repetition during this lecture. So again, balance is the process of maintaining the body's center of gravity within the base of support. The body's center of gravity rests slightly above the pelvis. One component often overlooked is the role balance plays within the kinetic chain. Within the kinetic chain, each moving segment transmits forces to every other segment along the chain, and its motions are influenced by forces transmitted from other segments. The act of maintaining equilibrium or balance involves the closed kinetic chain, such as the foot, the distal segment fixed beneath the base of support. The coordination of automatic postural movements during the act of balancing is not determined solely by the muscles acting directly about a joint. It is also determined via the indirect forces created by the muscles on neighboring joints. There is an inertial interaction of forces among the body segments, and a combination of one or more strategies can be involved to coordinate movement of the center of gravity back to a stable or a balanced position when a person's balance is disrupted by an external perturbation, also known as joint strategies. Injury to any one of the joints or its corresponding muscles can result in a loss of appropriate feedback for maintaining balance. To prevent a fall from occurring during an unexpected event, the body must correct itself by returning the center of gravity into a position within the limit of stability. Afferent mechanoreceptors provide input from the hip, the knee, and the ankle joints that are responsible for initiating automatic postural responses through the use of one of three possible movement strategies. The three principal joint systems, the ankle, knees, and the hips, are all located within the base of support and within the center of gravity. This allows for a wide variety of postures that can be assumed while the center of gravity is still positioned above the base of support. Motions about a given joint are controlled by a combination of actions of at least one pair of muscles working in opposition. These combined effects are to resist rotation of the joint relative to the resting position. The degree to which the joint resists the rotation is called the joint stiffness. The resting position and the stiffness of the joint are each altered independently by the changing activation of one or both muscle groups. Joint resting position and joint stiffness are inadequate for controlling postural movements on their own. The myostatic stretch reflex is the earliest mechanism for increasing the activation level of the muscles of a joint following an external imposed rotation of the joint. There are three strategies, the ankle, hip, and stepping, that have all been identified along a continuum. In general, the relative effectiveness of the ankle, hip, and stepping strategies in repositioning the center of gravity over the base of support depends upon the configuration of the base of support, the center of gravity alignment in relation to the limit of stability, and the speed of the postural movement. The ankle strategy shifts the center of gravity by maintaining the feet and rotating the body as a rigid mass about the ankle joints. The gastrocnemius or the tibialis anterior are responsible for torque production about the ankle. Anterior or posterior sway is counteracted by the gastrocnemius and the tibialis anterior, respectively. Each first slow center of gravity movements when the base of support is firm and within the limit of stability. This is also effective when the center of gravity is offset from the center. The thigh and lower trunk muscles contract by resisting destabilization of proximal joints caused by indirect effects of ankle muscles on the proximal joints. The hip strategy is relied upon more heavily when somatosensory loss occurs and forward or backward perturbations are imposed, or if support surface lengths are altered. This aids in the control of motion through the initiation of large and rapid motions at the hip with anti-phase rotation of the ankle. This is effective when the center of gravity is near the limit of support perimeter and when the limit of support boundaries are contracted by narrow bases of support. The stepping strategy is used when the center of gravity is displaced beyond the limit of stability. We either step or stumble, and this is used to prevent a fall. There are instances of musculoskeletal abnormality. We see this with damaged tissue, resulting in a reduced joint range of motion. This can cause a decrease in the limit of stability and places the individual at a greater risk for fall. Research indicates that sensory proprioceptive function is effective when patients are injured. Several methods of balance assessment have been proposed for clinical use. The assessment of a static balance in athletes has traditionally been performed via the standing Romberg test. This test is performed standing with the feet together, the arms at the side, and the eyes are closed. Normally, a person can stand motionless in this position, but the tendency to sway or to fall to one side is considered a positive Romberg sign, indicating a loss of proprioception. This test has been criticized for its lack of sensitivity and objectivity. It is considered to be a rather qualitative assessment of static balance because a considerable amount of stress is required to make the patient sway enough for an observer to characterize the sway. We also have the balance error scoring system, also known as the BESS. This uses three stances: a double, single, and tandem stance, both on a firm surface and a foam surface, for a total of 6 trials. Individuals are instructed to remain motionless with their hands on their hips and their eyes closed for 20 seconds. Any unnecessary movements or correction of the body's position are counted as errors, with a maximum score of 10 for each trial. The results are best used if they are compared to baseline data. Here are digital examples of the Romberg test and the BESS test. We can see the 6 trials of the BESS test on the firm surface and the unstable surface. Some examples of BESS errors would include the hands lifted off the iliac crest, opening the eyes, stepping, stumbling, or falling, moving the hips into more than 30 degrees of flexion or abduction, lifting of the forefoot or the heel, and remaining out of the testing position for more than 5 seconds. The BESS score is calculated by adding 1 error point for each error or any combination of errors occurring during one movement. An error score from each of the 6 trials are then added up for a total BESS score. Error scores from each of the 6 trials are then added up for a total BESS score. The higher scores represent poor balance. Semi-dynamic and dynamic balance assessments can be performed through functional reach tests, timed agility tests such as karaoke, hop tests, BESS tests for dynamic balance, a timed T-band kick, and timed balance beam walks with the eyes open or the eyes closed. Is to decrease the size of the base of the support in an attempt to determine a patient's ability to control upright posture while moving. Many of these tests have been criticized for failing to quantify balance adequately, as they merely report time of posture maintenance, angular displacement, or distance covered after walking. At any rate, they can often provide the clinician with valuable information about function and return to play capabilities. There are now commercially available balance systems to quantitatively assess and train static and dynamic balance. These systems provide easy, practical, and cost-effective methods of quantitatively assessing and training functional balance through the analysis of postural stabilization. The potential exists to assess injured patients and identify possible abnormalities that may be associated with injury. We can isolate various systems that are affected, develop recovery curves based on the quantitative measures for determining readiness for return to activity, and we can train the injured patient. Most manufacturers use computer interface force plate technology consisting of a flat, rigid surface supported on 3 or more points by independent force measuring devices. As the patient stands on the force plate surface, The position of the center of the vertical forces exerted on the plate over time is calculated. The center of the vertical force movement provides an indirect measure of postural sway activity. There are multiple manufacturers of these balance units. The Kistler and Burtech force plates are used for much of the work in the area of postural stability and balance. Neurocom has developed systems with diagnostic and training capabilities. However, it is important to note that manufacturers often use conflicting terminology to describe various balance parameters, and frequent consultation may be required with the manufacturer to decipher conflicting terminology between other manufacturers. Force platforms evaluate three aspects of postural control: steadiness, symmetry, and dynamic stability. Steadiness is the ability to keep the body as motionless as possible. This is a measure of postural sway. Symmetry is the ability to distribute weight evenly between the 2 feet in an upright stance. This is a measure of the center of pressure, center of balance, or center of force, depending on which test system you are using. Dynamic stability is often labeled as the ability to transfer the vertical projection of the center of gravity around a stationary base of support. This is often referred to as a measure of one's perception of their safe limit of support, as one's goal is to lean or reach as far as possible without losing their balance. Some manufacturers measure dynamic stability by assessing a person's postural response to external perturbations from a moving platform in one of 4 directions: tilting the toes up, tilting the toes down, or shifting medial or shifting lateral. Platform perturbations on some systems is unpredictable and determined by the positioning and the sway movement of the patient. In such cases, a person's reaction response can be determined. Other systems have a more predictable sinusoidal wave that remains consistent regardless of the patient positioning. Many force platform systems measure the vertical ground reaction force and provide a means of computing the center of pressure. The center of pressure represents the center of the distribution of the total force applied to the supporting surface. The center of pressure is calculated from horizontal movement and vertical force data generated by the triaxial force platforms. The center of vertical force on the Neurocom EquiTest is the center of the vertical force exerted by the feet against the support surface. The center of pressure, the center of the base, and the center of the force, and the total force are all applied to the force platform and fluctuates because it includes both body weight and the inertial effects of the slightest movement of the body that occur even when one attempts to stand motionless. The movement of these force space reference points is theorized to vary according to the movement of the body's center of gravity and the distribution of the muscle forces required to control posture. Ideally, healthy patients should maintain their center of pressure very near the anterior-posterior and medial-lateral midlines. Once the center of pressure and the center of force are calculated, several other balance parameters can be obtained. Deviation from this point in any direction represents a person's postural sway. Postural sway may be determined by using the mean displacement, length of the sway path, length of the sway area, amplitude, frequency, and the direction with respect to the center of pressure can all be calculated on most systems. An equilibrium score comparing the angular difference between the calculated maximum anterior to posterior center of gravity displacement to a theoretical maximum displacement is unique to the Neurocom's EquiTest. Force plate technology allows for the quantitative analysis and understanding of a patient's postural instability. These systems are fully integrated with hardware or software systems for quick and quantitative assessment and rehabilitating balance disorders. Most manufacturers allow for both static and dynamic balance assessments in either double or single leg stances, with the eyes open or the eyes closed. Neurocom's EquiTest system is equipped with a moving visual surrounding wall that allows for the most sophisticated technology available for isolating and assessing sensory modality interactions. Long force plates have also been developed by some manufacturers in an attempt to combat the criticism that balance assessment is not functional. The long force plate adds an array of dynamic balance exercises for training, such as walking, stepping up and over, side or crossover steps, hopping, leaping, and lunging. These important return to sport activities can be practiced and perfected through the use of the computer's visual feedback. Theories have stated that the failure of a stretched or damaged ligament to provide adequate neural feedback in an injured extremity may contribute to the decreased proprioception mechanisms necessary for the maintenance of proper balance. The lack of proprioceptive feedback resulting from injuries may allow excessive or inappropriate joint loading. The presence of a capsular lesion may interfere with the transmission of afferent neural code that is conveyed to the central nervous system. Decreased reflex excitation of the motor neuron may result from either or both of the following events. This may be caused by a decrease in proprioceptive central nervous system input, or may be the result of increased activation of inhibitory interneurons within the spinal cord. All of these factors may lead to progressive degeneration of the joint and continued deficits of joint dynamics, balance, and coordination. Joint receptors are believed to be damaged during injury to lateral ligaments in the ankle. This may occur because joint receptor fibers possess less tensile strength when compared to ligament fibers. This results in deafferentation and diminished signaling via the afferent pathways. Damage of the joint receptors is believed to cause articular deafferentation, diminishing the supply of the messages from the injured joint up the afferent pathway and disrupting the proprioceptive function. This is the reason behind balance training and rehabilitation. There is a decrease in the frequency of functional instability following ankle sprains when coordination exercises are performed as part of rehabilitation. We've also seen some research with orthotic bracing and intervention strategies. The enhancement of joint mechanoreceptors to detect perturbations and provide structural support for detecting and controlling sway has been increased through the use of orthotics or bracing interventions. For individuals with chronic ankle instability, they tend to be less stable as measured by sway amplitude. Questions exist in the literature regarding the loss and recovery of proprioceptive capabilities through the training and modification in movement strategies to enhance proprioceptive input. Increased postural sway and/or balance instability may not be due to a single factor. They may both be related to neurological and biomechanical factors of the ankle joint. Altered biomechanical alignment alters somatosensory transmission. This may result in deficits to the kinetic chain due to instability versus deafferentation. The ligament injury in the knee has been shown to alter joint position since detection. ACL deficient subjects with functional instability exhibit this deficit, which persists to some degree after reconstruction. This may impact the ability to balance on the ACL deficient leg. Mixed results have been seen in the literature when individuals are presented with static testing. Isometric strength could compensate for the somatosensory deficits. However, in the literature, the definition of functionally unstable varies. which causes some confusion in comparing the literature. The role of the joint mechanoreceptors with respect to the end of range of motion and the far reaches of the limits of stability may be impacted and should be addressed during rehabilitation. Additionally, more dynamic balance or hop testing may challenge the postural control system and should be incorporated with additional mechanoreceptor input. Balance and head injuries. The neurological status following a mild head injury has been assessed using balance as a criterion variable. Additional testing is necessary in addition to balance and sensory modalities. Postural control systems that link the brain and the body's communication is affected during a mild head injury. Unfortunately, postural stability deficits are often found in head-injured patients. These deficits may last up to 3 days post-injury or sometimes even longer. Research has suggested that this balance deficit is the result of a sensory interaction problem. The visual system is not used effectively following head injury. Objective balance scores can be used to determine recovery curves and also for making return to play decisions following a head injury. Using balance training during rehabilitation. Developing a rehabilitation program that includes exercise for improving balance and postural equilibrium is vital for a successful return to competition following a lower extremity injury. The injury has caused a disruption at some point between the body's center of gravity and the base of support. This is likely to have caused compensatory weight shifts and gait changes resulting in balance deficits. These deficits may be detected through the use of functional assessment tests and/or computerized instrumentation assessing balance. Having the advanced technology available to quantify balance deficits is an amenity, but not a necessity. Imagination and creativity are often the best tools when there are limited resources while designing balance training protocols. Functional rehabilitation should occur in the closed kinetic chain, such as the nature of the sport. Movement speed and additional resistance may be more easily controlled in the open kinetic chain initially. We need to make sure that we have adequate and safe function in the open kinetic chain. This is critical and should be the first step in rehabilitation, but should not be the focus of the rehabilitation plan. Every attempt to progress the patient to functional closed-chain kinetic exercises quickly and safely should be made. Depending upon the severity of the injury, this could be as early as 1 day post-injury. A variety of activities can be used to improve balance, but the therapist should first consider 5 general rules before beginning. The exercise must be safe and challenging. It must stress multiple planes of motion. It should incorporate a multisensory approach. It should begin with static, bilateral, and stable surfaces and progress to dynamic, unilateral, and unstable surfaces. And it should progress towards sport-specific exercises. We need to make sure that we use balance exercises in an open area where if the patient falls, they will not be injured. Assistive devices should be in arm's reach early in the training. Devices such as chairs, railings, tables, or walls can be helpful for the patient if they lose their balance. We can use either sets and repetitions or time-based protocols. The patient can perform 2 to 3 sets of 15 repetitions and progress to 30 repetitions, or 10 of the exercises for 15-second periods, progressing to 30-second time periods later in the program. Static balance, the center of gravity is maintained over a fixed base of support on a stable surface. For semi-dynamic balance, the person maintains the center of gravity over a fixed base of support while on a moving surface, or the person transfers the center of gravity over a fixed base of support to selected ranges and/or directions within the limits of stability while on a stable surface. Dynamic balance is the maintenance of the center of gravity within the limits of support over a moving base of support while on a stable surface. And finally, functional balance. This is the same as dynamic with the inclusion of sport-specific tasks. Phase 1 of our exercise and rehabilitation program, including balance. This usually includes non-ballistic type drills, static balance training, bilateral to unilateral on both involved and uninvolved sides. It may include the use of multiple surfaces to safely challenge the individual and maintain their motivation. We can take away the patient's arms by having them place their hands on their hips. The arms are used to counterbalance and assist with balance. We can try this with eyes open or eyes closed. We can also alter a variety of sensory information. We can add perturbations, which are slight touches to the individual. We can incorporate a multi-axis device and train reflex stabilization and postural orientation. In Phase 2, there is a transition from static to more dynamic balance. Dynamic balance is important to those patients who perform running, jumping, and cutting activities. Also, activities that require the patient to repetitively lose and gain balance in order to perform activity. This should be incorporated when sufficient healing has occurred. We start including range of motion, muscle strength, and endurance. Semi-dynamic exercises should be introduced in the transition. This involves the displacement or the perturbation of the center of gravity. This may include things like sit-to-stand exercises, focusing on postural control. This includes also bilateral and unilateral stances or weight transfers. Here are some additional exercises that can be used in Phase 2. We can see Phase 2 may take a little while to progress through. For Phase 3, dynamic and functional types of exercises should be utilized. Slow to fast and low to high forces, and then controlled to uncontrolled. This depends on the sport the athlete is involved in. We start with bilateral jumping drills in a straight plane. Then we advance to jumping patterns, and then advance to diagonal jumping patterns. We can increase the length or the sequence of the patterns and progress to unilateral drills. Pain and fatigue should not be much of a factor in this stage. We can also add a vertical component to the drills, and the addition of implements such as resistance, tubing, beams, or walking on a foam roll. This is the final step, and functional activity with subconscious dynamic control and balance should be emphasized. Another aspect is dual task balance training and assessment. Our patients split their attention between the cognitive and balance tasks during sport participation all the time. This is a final progression for musculoskeletal or neurogenic injury and should include motor and coordination that is paired with cognitive tasks. Cognitive and balance are unique but are linked to the attention system. These dual task exercises help to keep our patients engaged. They also reproduce the demands experienced during physical activity. They must be clearly explained to the patient and can be sport-specific. There is a clinical value of high-tech training and assessment in balance. These balance systems allow for the deficit detection and quantification of assessment. This type of balance assessment is used both clinically and in the research settings. Multiple tests are available and a variety of variables can be assessed and monitored with respect to performance.